stop freaking out, okay?
So this drug calculation,
That won't be too funny. She can't even listen.
I told you. When I seen it, I said, oh
so
no.
this is what you're talking about for cardiac.
I was like, this is not right.
Oh my God.
No, see, y'all freaking out, but it's not hard.
Oh,
Right now, y'all can't see. Did everybody have it with them?
no.
Okay.
I
said, ooh,
have it at
no.
home. I thought we needed just to memorize it for
No,
today.
you don't need to memorize it. It's something you will be able to use actually on the exam day.
Oh.
All right, so when we get to that, bring it back. Bring a highlighter because I'm going to show you how to use it. That makes it so much easier. And I'll give you some practice ones we'll do in class that day. So you start freaking out. It's not so bad. It just looks like a lot of craziness. But once you read it and do it, you'll figure out that it's okay. All right?
Okay, I see all the cardiac drugs now.
Yeah. It's kind of like, what?
I was just sitting here trying to memorize the conversion. I'm serious. I thought the test was tomorrow.
Now, why would I introduce something like that for overnight? Y'all know.
Sorry, I think I asked.
I am bad, but I'm not quite that bad.
You just don't know what to expect now.
You didn't even look at it.
All right. Calm down. You're going to be all right. All right. So don't freak out. You're going to be okay. All right. So that's, but we'll go over some math stuff. So don't freak out about that. One of the things you want to make sure you kind of, because you know you got a quiz next week that you're looking at respiratory stuff. So kind of look over the A and P piece again. I might end up doing it electronically for your group. It may not
Yeah, that would be awesome if you get all of them instead of any written.
You mean,
You need to stop.
It'll be easier for you, Mrs. H. Just put it through that machine and grade it.
All right. My other class is math. We'll see what happens with them. I haven't met them yet, so we'll see. If I come back after tomorrow, things will be good. All right.
Well, boy.
Now,
Send Bree a second one.
Yeah, I know, right? Keep your class happy.
the thing that's a little bit different is for, there's a separate thing for shock, but as we do different systems, I will do the shock that goes along with that. Mainly because to me it's easier to do it that way instead of doing a whole different test on just shock itself. So when we're doing respiratory failure and R's are the shock states pretty much when you think about what's happening with that. When we do cardiac, we're going to do cardiogenic. When we do neuro, we're going to do neurogenic shock. When we talk about hematology, we're going to talk about septic shock. So there won't be a separate shock test. The elements of what happens with shock patients will be related to content. To me, that's a lot easier to do them that way. I know there's people that do them all together, but to me, it's just easier when you think about the worst case scenario for what system you're studying. It makes it a lot easier to follow about what's happening with your patient. So that's where your paperwork is for your different things. When we get down here to leadership, this is going to come up when we do our leadership orientation. So just so you know, there's all the paperwork that you're going to need as far as forms, that kind of thing. There may be another form that I put up here a little bit later because this kind of tells you about your information sheet for your preceptor, what the preceptorship is supposed to be about, the preceptor role. So all the stuff that you need for leadership is actually there. Okay? So just know that we'll talk about it more when we get closer to that time, but I try to put everything that you're going to need on your homepage. Okay? So hopefully everything is kind of set up nicer for you as far as your classroom goes. But if you're on the home page, you should be able to get to everything. If there's anything new, I will send it to you out in an email or an announcement, something like that. Okay. So far as Ms. Palmberg will probably be out here to talk to you guys later in the semester because she has some stuff she wants to go over as far as getting your licensure stuff done sooner than later. That's one of the things that we find that students are doing much better as a group when they take their tests early. And I know there's always constraints about time and all that kind of stuff. You get into the holidays. There actually is a student who is was one of the evening students I had in the class, and he took we finished the semester on December 8th. He had his license Christmas Eve. So it all depends on how fast you get your paperwork there, kind of thing. So I'm not saying you got to get it done that quick, but it will be a nice Christmas present, and you can give you more stuff. So that's more things they can get for you. So that's it's a thought process about how you make sure that's done, or if you have somebody that you'll have your review course, all that kind of stuff, and you should be ready to go. The major thing about that whole thing is it has to be. It's like a perfect storm. School sends your grades and to the state of Florida, says yes, that's done. Pearson is paid, the state of Florida is paid. Once they all come together, you get your sit pass. Once you get it, you have 45 days to schedule your exam. And like I said, sooner than later is the better thing to do. For the NCLEX review, it will be somebody that's here. I can't do it, so it will be somebody that comes from outside of our school that does that review. You'll be at Dale Mabry campus is where they usually do that one. They are there for 3 days. They go over, essentially there's a little review book for the NCLEX exam. So it's a lot of stuff you go over in a 3-day period. Most of the med-surg stuff you will have had because you've been in NP2 and NP4 with me. OB and Peds, that's a whole nother thing. That's the part of the book that's memorization, because the things that you have to do as far as kids go, the developmental milestones are all the same. Stages of labor are always the same kind of thing when you're looking at your NCLEX. Because that's what it is. You're going to pass this class and you're looking forward to making that test that's going to cost you money kind of thing. That's what you have to be looking at. But that's, they'll give you more information, and I'll put it up as that comes along about the NCLEX review course. But that's generally on Dale Mabry campus. So you know how it is parking over there. And parking on Wednesday ain't going to be nice either. I'm just
Especially
telling
it's
you.
the fall, it's not the
What
summer
time?
anymore.
12:30 on Wednesday.
Yeah.
So I don't know if you guys, if some of y'all can carpool or however you want to do it, because you know it's not. Plus we actually are supposed to be breaking the ground on a new building for all the health sciences, so they even took one of the parking lots of them. So it's like madness right now. So I'm just saying, it's not going to be pretty.
If we go at 8, would it be better?
Huh?
If we get there by 8, we'll get parking?
Yeah, but that's unless y'all go sit there and study till, because I don't have a classroom till that time. That's up to y'all, however you want to do it. I'm just saying, it's kind of, you always know it's crazy when we start a new semester. I don't even know where I'm going to park when I go over there. We'll see what happens, kind of thing. All right. So, of course, we have content now we're going to look at. All right. So, based on, those are the syllabi. Those are done. Any other questions about syllabus or testing or any of that stuff before we go into content class?
The mandatory review course, Wednesday, Thursday, Friday, what time we have to be there?
It's usually either 8 to 4 or 9 to 5. The person who sets the day who comes here to do it, who's coming here to do your course usually talks to the group how they're going to do that part. You always get an hour lunch or a 45-minute lunch in that one, but they essentially it's so funny because I've never had. I mean, I've been doing it for about a year now, and sometimes you'll have groups that hate it because they're mandatory, and then you have other people that are, oh yeah, let's learn. So those are actually good days. But when you have people that absolutely hate it, it makes for a long day. So all you have to do, even if you don't want to be there, just sit in that like you want to be, for 3 days, and then you
So
get out.
6, 7, 8.
And then you get a voucher at the end. So you sit there for 3 days for $200. That's essentially what you're doing. All right. So once that review is done, you're gonna get a voucher that you can pay for your NCLEX exam. Because one of the things that we are even talking about doing, just so make sure everybody does it, is to actually have everybody sign up that day. Open up the computer system on the last day, and everybody register that day. You got your voucher number, you register, and then that way it's done.
Yes.
So we're thinking about doing that. So that's why she may end up coming talking to you about it, because you got to figure out how the logistics of doing it. But that may be something that happens during that time. All right. So for our content areas, we're going to be looking at airways pneumonias, our ARDS patient pulmonary kind of problems and that kind of thing. Our major issue, of course, when we're talking about respiratory is oxygenation. So you got to think to yourself when you're doing NCLEX type questions, what are the things that indicates the patient is hypoxic? Or that I have a patient that has an issue with oxygenation. So that's what you're looking at as far as the problem with the patient. All right. So one of the things you have to think about when you're looking at oxygenation or a patient has a problem with it are those signs and symptoms you're going to see associated with a patient who's having issues with oxygenation. What are some of the things the patient may be complaining about or that you might see on examination? Shortness of breath.
Decreased respiration.
Decreased respirations. What else can we see? Accessory muscles. And this is never normal in an adult. You may see it sometimes in kids, but if you ever see it in an adult patient, it is never normal. Okay, so that's one of the things you got to think about. What if I'm seeing this person that's having accessory muscles, retractions, those kind of things tell you this person is having respiratory distress. What are they going to look like?
Blue.
They may be cyanotic. Always remember, when is cyanosis?
Late.
Last.
All right, so you don't ever want to wait till the person gets to that point. All right, because cyanosis is always late. So when they're blue, call the priest, kind of thing. Don't keep waiting until they do that. Because the first kind of things you see in a person who's having a problem are really going to be things like agitation, confusion. Mentation is going to be affected. So a lot of times they may be picking at stuff in their room. They may tell you something off the wall, kind of thing. Those are the things that you usually see early on. So changes in mentation, confusion are the things that you see first. Now, depending on what's going on with them, you're going to see these and other things happen with your patients. Because if they're short of breath, their heart rate is elevated. Okay, because those are things that you see what's associated with that. You think about those signs and symptoms that I see associated with a patient who's having issues with hypoxia. Blood pressure goes up initially, but then it drops as hypoxia continues. Heart rate always stays up. But those are things that you're going to see associated with this patient having a problem. Okay? So we want to fix that. We don't want to wait till this continues on, the patient keeps having a problem, oh my God, what am I going to do? You want to catch them early. Okay? Now, depending on what's wrong with the patient, whether it be something that is a embolus, so that's a clot, whether it be respiratory failure, that's a relative or refractory hypoxia. You got to think about what is the root cause of what's happening with the patient. And that's why you have to think globally. Think about all these people are going to be experiencing problems with oxygenation. So I know their O2 level is low, PaO2, SaO2. Remember, saturation is SaO2. That's what you do on the finger. On your blood gases, that's PaO2. But both of those numbers are going to be low. So what you have to do is look at what is the root cause of what's happening with your patient. And that's how you have to kind of think about what's going on with the person. That's what happens on this sheet that you're looking at. So we got oxygenation issues that we're looking at. We have some that are obstruction, which were things we did before. Then we have our upper respiratory tract and lower respiratory tract problems. So we're going to talk about pneumonia first, because that's what fits in that category. Okay, so those are things that we're going to see with our patient. And we had a couple of different pneumonias to look at, right?
Cough, cough, and hop.
So we had pneumocystis, which was PCP. We had hospital-acquired pneumonia. You were right. We had CAP, and we had VAP. All these different things. Why do we have all these abbreviations? Just to make us crazy. So you don't have to write it all down. So PCP is pneumocystis carinii. Oh, we got Legionella here too. Only one that's not sure. Okay. So pneumonias, we got to think about what's happening with the patient. This is an acute infection that's happening in the lung parenchyma, or the lung tissue. when you talk about patients having pneumonia. Leads to consolidation. It's the area where you actually have an airless alveoli. So that's what ends up happening in patients who have pneumonia. Part of the reason why if I have an airless alveoli, don't you notice that sometimes when people talk about pneumonia, they don't hear any air moving in that part of the lung. That's what's happening. So that leads to consolidation that's there. So we're going to talk about more than 3 different types. 5 different types of pneumonia. So the first one we're going to look at is pneumocystis. Really long name. And what do we usually see pneumocystis with? What type of patient?
AIDS.
AIDS patient. It's considered an opportunistic infection because pneumocystis is not something that should be happening to a normal person. The only other time that you generally see pneumocystis other than HIV is going to be associated with a person who is immunosuppressed for whatever reason. So that's a chemo patient, right? Because that's a person that can be immunosuppressed. A patient has a myelodysplastic syndrome, which is usually something that precedes a leukemia type thing. So, because pneumocystis is in the environment, but if you have an intact immune system, you don't have a problem. Because this is considered opportunistic disease, meaning that you have to have some impairment of your immune system for this to be a problem. But primarily you see it in HIV patients. Now this patient has hypoxia. They usually have a high temp because it's a fever associated with it. This person also has a rattly type cough, but they rarely bring up any sputum. They sound wet when you listen to their lungs. But a pneumocystis patient has very few secretions. It's the weirdest thing ever. And mainly because there's some discussion about, because there's some, PCP is one of those that they said was a protozoa initially, so that's why they don't produce all this exudate, that's why they don't have a lot of sputum. So there's some things that we talk about as far as relationship to that. But if you listen to the patient, their lungs sound wet. And when you hear a person that's wet, what do they normally have? Sputum production. But this person is dry, hacking cough. Very dyspneic. Raise the head of their bed, think they don't get better. Now, even with treatment, patients who have pneumocystis have a survival rate of about 3%, even if you treat it. So that's why it's a bad disease to have, mainly because it doesn't respond well, because these people don't have an intact immune system, so it's problematic for them. So high mortality rate associated with PCP pneumonia. So for this group of people, because we know that this is a high incidence happening in these patients, is that we try to do preventative therapy for them. This is one of those times where patient teaching, preventative therapy, what I want to do for the patient. So patients who have HIV may take a drug that has nothing to do with their HIV status, but is, I shouldn't say status, but nothing to do with HIV disease itself, but as a preventative measure for developing PCP. And the drug they take is Septra. You know that is a sulfa drug, so you have to look for allergies to sulfa drugs before a patient takes it. What do you normally see Septra given for? UTI. Patient doesn't have that, but this is what actually prevents them from getting PCP. So sometimes you'll see them take that. The other thing a patient can do, because this is an everyday drug, so it's like suppressive therapy or preventative therapy. There's another way that you can treat this, and a lot more patients are doing it this way, is you can do a respiratory treatment with a medication called pentamidine. Patient takes a respiratory treatment once a month, and it's enough to prevent PCP infection. So you will see that sometimes given to patients. Much because you know how it is, patients are going to be compliant with stuff they have to take less time. So this is what you see a lot of times given to patients instead of pills.
That's given with nebulizer?
So they give it to them as a respiratory treatment once a month. Provides the preventative effect for them developing PCP. But think about your patient at risk. In an NCLEX question or your test question, patient is immunosuppressed, patient has HIV, the pneumonia you're thinking about is PCP. Or if you see in the question, patient has a dry hacking cough with a high fever, because most pneumonias produce sputum. This one doesn't. Patient chest sounds horrible, but you're not bringing up any sputum. But they can get very hypoxic. And part of what makes this patient different, when you're looking at patients who have pneumonia, generally you see a gray looking appearance to their lungs. When a patient has PCP pneumonia, it looks bright white. You know how when if you're ever in an ICU, you see the light board or that thing that we put x-rays on? When you see a patient with PCP, all you see is their ribs. The lungs look like it's just white, like the board. So we call it whiteout. When you see that, you know it's a PCP pneumonia. Because nobody else does that except these people. Now, even with treatment, 97 out of 100 of these people die. So the reason that you do preventative therapy is to prevent that from happening. So that's why you'll see it as a routine piece of treatment for patients who have HIV. Unless you can keep that viral load down and their T cell counts up, you're going to see a patient on these medications. But it doesn't tend to happen to the general population. Primarily you see it in HIV patients or anybody else who's immunosuppressed. Now the second and third ones kind of go together. Okay, so HAP, which is hospital-acquired pneumonia, and then you have CAP, community-acquired pneumonia. Both of these are pneumonias in the typical sense. Patient has a temp, shortness of breath, cough, all those things are happening. As they get worse, of course, remember, pneumonias generally start in one place. If you continue, a person's not moving around, they get more confluent, meaning it's going to be more of the lung that's involved. So you have a patchy atelectasis happening at first, then it becomes a big area of consolidation in the patient until it can take over a whole lung. Those are really sick people that happens to. One of the things that kind of dictates that is the virulence of the organism. So if it's something that's very virulent in nature, a patient can die within hours. Case in point, Jim Henson, the guy who created the Muppets, had a pneumonia with a virulent organism, was dead in 5 hours. So it just depends on what they end up having. Okay, he didn't have any chronic diseases or any of that kind of stuff, but the virulence of the organism he had killed him. So a lot of that depends on what it is that you're growing. Now what's weird about pneumonia is that even if I know you come in here with all this sputum, you got a temp, it's green colored, all that kind of thing, about 50% of the cases will not culture anything. That is the weirdest thing known to man, but it's the truth. You see all the symptoms, chest x-ray reveals the patient has pneumonia, the patient has a temp, they have general malaise, all the stuff that goes along with having an infection. But if I do a culture because they have sputum, there are times when half the patients will not even culture out anything. So you can't even tell what they have. So we have to treat them with broad spectrum antibiotics. Okay? Now the reason that these kind of go together is because this is a big deal. All right? All of them are a big deal. But this one is a big deal because of reimbursement. Okay? Because a hospital-acquired infection means you own it. Okay? So hospital-acquired pneumonia is considered a hospital-acquired infection, or a HAI, as they're known now, which is one of those core measures. So that comes back to money for the hospital. Minimum cost associated with a patient who has an infection that's hospital-related is about $40,000. So that doesn't have anything to do with the morbidity associated with it. Just the minimum cost associated with an infection that happens in-house is $40,000. What if a patient ends up with something really bad and is there for 6 months? The hospital can eat that 6 months hospitalization for the patient. So that's why it's a big deal, talking about hospital stuff. But hospital-acquired pneumonia tells you that it happens within a certain period of time. Okay, so hospital-acquired pneumonia says that the patient has the onset of pneumonia symptoms after 48 hours. Because that tells you what happened with the community one, right? Patient either presents to the hospital or symptoms are present within 48 hours. Says you got it outside. That's where you want everybody to be. Okay? That's why I say those kind of go together, because the symptoms, all that kind of stuff you see with the patient are the same. It's the timing of the onset of things that are happening with the patient that makes the difference. Hospital-acquired after 48 hours, patient being in the hospital. So if you get a question that says third day, patients develop symptoms of, that's hospital-acquired pneumonia. If patient comes to the hospital with symptoms, or they happen within 48 hours, it's considered community-acquired pneumonia. Okay, so that means you got it outside. I'm gonna treat you, but that means your insurance company gotta pay me. So that's what you want happening with your patients. Okay. Now, if I have a patient who has CAP, one of the things that you can do, and part of what we end up treating patients for, because you don't always have to put a patient in the hospital because they have CAP. You know, you got a person that's feeling bad at home, they go to their doctor's office, they try them on antibiotics first. If they don't get better, they end up going to the hospital. Okay, what is the thing we give most often now for antibiotics? It's very bad because we overuse it. Z-Pack. Don't like this trick. Mainly because we overuse it so much now that so much stuff is resistant to zithromycin now. It's crazy. Zithromax is not the drug we use. And the thing about it, the reason you use it is because it used to be 7 days. Now we have Z-Pack for 3 days. Okay, because they have a 5-day one and there's a 3-day one. Compliance is fantastic, but because the organisms are not are resistant, you still may have to treat the patient with another drug. So just know, we give broad spectrum first. Then if that doesn't work and we put them on other stuff, they may put the patient on a cephalosporin. If that doesn't work, we go to the drug that was the best of all, Viaxin. Patients don't like it because it causes a lot of GI side effects. The other thing that Viaxin does is make everything taste like metal. It is funky, but it works. All right, so you'll see that happen with patients. All right. So you're talking about timing of symptoms that happens with these patients. But what is the order of things you do for anybody that comes in with a suspected pneumonia? What do you do first?
Culture.
Always, always. Here's study. Second,
X-ray.
not X-ray. Antibiotics.
Antibiotics.
And then you go to any other thing I have to do. And I'm just going to put any other thing. So that can be an X-ray. If you have a patient in the question that says patient complain of a headache or pain, pain is still managed after these things are done. You want to see what I'm growing, then I want to give you an antibiotic to cover everything, and then I address other issues that you have. Even though pain is horrible, and you know it's a physiologic thing I have to deal with this particular thing I need to do a culture first. And to see what it is that you have. So blood, sputum, that's what I want to do first in my patient. Give them their antibiotic, and then address any other issues the patient has. Even if they have a temp, even if their temp was 103, you still do these first. And then you address them with their Tylenol. Okay. So those are things when you talk about community-acquired pneumonia. Now VAP, of course, is the pretty easiest one up here. Because what is it? It's ventilator associated, so it tells you what happens to your patient. All right? So this person has an ET tube or some type of ET tube or trach or whatever it is. They are connected to a ventilator, and so now this patient develops pneumonia. This is something that we don't want to see happen with your patients because this is also a hospital-acquired infection. Okay? So that's a bad thing. But, so you're really going to eat costs on this one because there's protocols that kind of go along with patients who have VAP and how we try to prevent that in patients. Okay. Ventilator-associated pneumonia patients have to have the head of their bed elevated. They get oral care every 2 hours with chlorhexidine. So there's a tooth kit or mouth care kit you're supposed to use on a patient. You're supposed to change out all their tubings and that kind of thing every 24 hours. So there's a protocol that goes with VAP. So I want you to kind of go to the CDC website because they have a bundle when they talk about VAP. These are the things you're supposed to do when a patient has ventilator-associated pneumonia. Elevate the head of the bed at least 30 degrees, not 60, not 45. It has to be at least 30 degrees because that's what they're going to ask you in an NCLEX type question. If you raise at the high